Hello everyone, my name's Jane Roberts. I'm a Medical Affairs Dietitian at VitaFlow International Limited, and I'm very happy to welcome you to today's webinar hosted by VitaFlow, titled Cognitive and Psychosocial Considerations in Pediatric Chronic Kidney Disease. This webinar aims to support healthcare professional education with regards to the dietary management of pediatric kidney disease. Few housekeeping items before we get started. The webinar is intended for healthcare professionals only and will last about 90 minutes, and that will include time for questions at the end. If you'd like to ask a question, please use the question feature on your screen. All the questions will be screened and a select number will be answered by the speaker at the end of the presentation. The webinar is being recorded and will be available on VitaFlow's website for healthcare professionals in a few weeks' time. PDFs of the presentation slides are available on your screen for download. A certificate of attendance and a self-reflection tool will be sent out by email following the webinar. The views herein are of the presenter and do not necessarily represent VitaFlow's views. The material is accurate as of the date it's presented and is for educational purposes only, and it's not intended as a substitute for medical advice. The learning outcomes for the presentation are documented on this slide. We're fortunate to have a host of experts included in today's webinar. Professor Lindsay Harshman from the University of Iowa, Professor Larry Greenbaum, Professor of Pediatric Nephrology from Emory University and Children's Healthcare of Atlanta, dietitian Vanessa Shaw from UCL Great Ormond Street Institute of Child Health in the UK. Professor Lindsay Harshman is the Medical Director of Pediatric Kidney Transplant at the University of Iowa Organ Transplant Centre, as well as the Assistant Programme Director for Resident Research in the Department of Pediatrics. Her research interest focuses on neurocognitive and neurodevelopmental outcomes in the pediatric chronic kidney disease population. Clinical interests focus on research concepts of brain growth and development in a chronic kidney disease life course, specifically in the pediatric renal transplant population. Professor Harshman is on the Council for the American Society of Pediatric Nephrology and a member of the American Society for Pediatric Nephrology Research Committee, Improving Renal Outcomes Collaborative Research Committee, and the American Society for Pediatric Nephrology Workforce Committee. She's also a recent Pediatric Renal Nutrition Task Force member. Vanessa Shaw is an honorary senior lecturer at UCL Great Ormond Street Institute of Child Health and was head of dietetics at Great Ormond Street Hospital for Children, London, until 2017. Vanessa is a reviewer for Pediatric Nephrology and Journal of Renal Nutrition and co-chair of the Pediatric Renal Nutrition Task Force. Professor Larry Greenbaum is the Division Director of Pediatric Nephrology at the Emory School of Medicine and Children's Healthcare of Atlanta. Professor Greenbaum conducts clinical research in a variety of areas in pediatric nephrology, including renal osteodystrophy, cystinosis, renal nutrition and chronic kidney disease. Professor Greenbaum has served as President of the American Society of Pediatric Nephrology and as the Chair of the Executive Committee on the American Academy of Pediatrics Section on Nephrology. Without further delay, I'll now hand you over to today's speaker, Lindsay Harshman. Over to you, Lindsay.
Good morning, everyone. I guess good morning from the United States. I know we're crossing multiple time zones with this presentation, but it's a great way for me to start my day joining you all to give this presentation today. Again, my name is Lindsay Harshman. I am at the University of Iowa in Iowa City, and I'm here today to talk about cognitive and psychosocial considerations in pediatric chronic kidney disease. This is a topic that I probably could talk about for hours, so I've tried very purposefully to condense it down into about a 50-minute talk or so, potentially a little bit longer, and then plenty of time for questions. I would love to take questions and just have a dialogue and discussion on this topic. Please feel free to put questions in the chat as we go along, and then we can circle back to them at the end of the presentation. Again, my topic, cognitive and psychosocial considerations in pediatric chronic kidney disease. And we're going to approach this really taking basic nephrology care and intersecting that with neuroscience. I hope this is a enjoyable topic for everybody today, and something maybe that is a little bit new for you that you can take out into your day-to-day practice. I am supported from the National Institutes of Health through a current R01 and have some internal funding, which I would like to acknowledge before I get going. I'd also like to thank VitaFlow for inviting me to do this presentation today. As we get going, I do want to break this up into a general outline for you all. And in just a moment, I will also frame this in the context of nutrition, because I recognize, again, VitaFlow, the purpose of VitaFlow is to help us provide great nutrition for our patients. And so this topic may be a little bit different than some of the topics that have been touched upon previously in these webinars. But again, I think it's important in the context of the global patient and how we take care of our patients. So today we'll take a tour through four sort of broad topics or content objectives. First, taking this as a lifespan approach and trying to understand how we take care of little ones with chronic kidney disease clear through adulthood. How do we help them best through the lifespan? I'm going to take that then and we'll sort of frame our topic and why do we even care about the brain in a non-neurological disease. Next, we'll go into the topics of cognition and neuroimaging in pediatric chronic kidney disease. And finally, wrapping it all up and taking it beyond the cortex, how do we improve outcomes for our patients with chronic disease, specifically chronic kidney disease? So for our patients with chronic kidney disease in the pediatric world, many of them, this is a lifespan issue. Meaning that the majority of our patients with pediatric chronic kidney disease are born with some form of congenital anomalies of the kidney and urinary tract. Some of our patients are extremely small when they are born and diagnosed with chronic kidney disease or chronic kidney disease precipitating factors. And so I really like this slide because I think it helps us to put into context how small many of our babies are when they come to us with chronic kidney disease and the fact that we have to take care of them through the lifespan. So certainly with our kids with chronic kidney disease, they are born with piping and plumbing issues where you can see that the kidneys are potentially malformed from the get-go, hydronephrosis, as you can see on this kidney slide here. This baby that's shown in the middle, reproduced with permission. The baby was actually born under 1,000 grams and had twin transfusion syndrome. So the kidneys essentially had poor perfusion in utero and postnatally and required dialysis as a very, very small baby. And then currently, because of the neonatal events suffered by the baby, does have chronic kidney disease. So again, just framing this in the lifespan perspective that many of these patients will be our patients through much of our careers. So then that leads me to ask, why do we study the brain in kidney disease? I've just told you that many of our patients are born with chronic kidney disease and they are going through a lifespan, their toddlerhood, their early childhood, their adolescence with a chronic disease state. And so it shouldn't be that surprising to us then that if there are neurocognitive or brain thinking, judgment, decision-making capabilities that are maybe not up to par with healthy peers, these neurocognitive difficulties can interfere with quality of life. They can interfere with compliance with medical requirements for advanced chronic kidney disease and even post-transplant care. And again, kind of keep this thought in your mind as we go along, because that's really important as we think about the things we ask our patients to do nutritionally. Compliance with nutrition, potassium restrictions, phosphate restrictions is hard. And so if patients have difficulty with remembering or paying attention to directions, then that starts to sort of set the cycle for potential nutritional ramifications down the line. So in the last 3 slides, I hope I've started to set up for you that today's talk should be very relevant for each and every person in this webinar. Again, chronic kidney disease is a lifelong process. There is no cure per se. For each of our patients that has chronic kidney disease, there is a transition again from early stage CKD to dialysis and transplant among a notable number of them. And Unfortunately, again, transplant is not a cure. It simply resets the chronic kidney disease life cycle. So as we think about caring for our patients holistically, understanding how the brain and the kidney kind of work together potentially gives us the opportunity to really provide critical interventions across a variety of domains, again, holistically for our patients, as we look at adherence, education and career outcomes, and in general, health-related quality of life. So as I mentioned, I told you I want to make sure that this is relevant also to those that are in the room who may be non-physicians, who maybe are dietitians on the team, are nurses on the team, nurse practitioners, whatever your role might be. Framing this holistically, I think, is important. And so nutrition is such a cornerstone of what we do for our patients, how we help them to stay as healthy as possible in a chronic kidney disease state. So understanding how when we give a patient instructions about decanting, or a family decanting feeds, or hey, let's avoid this chocolate or this soda because of the phosphate component. If our patients can't understand or comprehend what we're saying because we're putting the directions out at a level that is cognitively above where the patient is at, then it should be no surprise to us that if they come back next month and the phosphate is still 9, that maybe it's on us a little bit to help how we're putting our instructions out for our patients. Similarly, again, ability to adhere to complicated routines. Adherence, as we'll talk about, really relies on pretty high level cognitive capabilities, memory, attention, and a component that we'll talk about called executive function. And certainly, I don't want to underestimate the effects of educational outcomes on our patients. Education certainly has a direct link with one's financial stability in life and your financial resources. It can be challenging to afford healthy foods that are kidney friendly. I think we're all very aware of that. So education and mental health all play in together. And so take this talk again into the clinic and think about how our cognitive complications of chronic kidney disease can impact nutrition. So why the brain? Why should we be thinking about our patients' cognitive capabilities and cognitive development in a non-neurological disease? This is one of my favorite slides to show because I think it really sets the stage for why brain development is so critical amidst chronic kidney disease in our pediatric patients. Brain development is a prolonged process. And so what you see here is this, over time, this, I would say, gray matter pruning or dendritic pruning. Our brains are made of white matter and gray matter being really the cell bodies of the neuron, and the white matter being the myelinated and true neuronal components, the highways that connect the cell bodies together. So over time, there's actually a very purposeful developmental reduction in gray matter that occurs over time. And as the gray matter decreases, the volume of gray matter with this programmed elimination, the white matter connections strengthen. So you're forming better highways between the gray matter components. So I want you to kind of keep this slide in your mind as we go along, because it'll be very important as we talk more about brain differences on neuroimaging in this population later. So we've just said that over time, I'm going to go back one slide. Over time into your early 20s, these brain changes are occurring. White matter is getting more dense, gray matter is getting less. And so we think about the early 20s for many of our patients, age 18, 19, 20, 21, they are transitioning to college. They're transitioning to independent jobs. And so imagine being 19 in college with a medication list like this, trying to navigate classes, trying to navigate being a transplant patient. And then your care team saying, hey, actually, you need blood pressure medication too. You need vitamin D. You need to take your transplant immune suppression, all of these things. I mean, I always tell my patients, I can barely remember to take 2 medications per day, like a vitamin and an allergy medication. How difficult is it to take this list of medications? It has to certainly be challenging. And so keeping those things in mind is really, I think, critical as we help our patients understand the reality of what we're asking them to do. Now, so again, we've just said in the last two slides that this sort of 18 to 21-year-old timeframe is developmentally, there's a lot still going on. Patients are transitioning into independence. Their brains are still developing. And many of our patients are dealing with complex care routines. So for example, our transplant patients who still have chronic kidney disease within the allograft. One of the slides I think that, again, I want you to keep in context and keep in the back of your mind as we move through this talk is the idea that with these challenges and transitions in life, it can certainly put our patients' health at risk. So this slide is, again, very, very sobering to me when we look at the risk for graft failure in a transplant patient during emerging adulthood and transition to adult care. This really dramatic spike in allograft failure probably shouldn't be so surprising when we think of these transition periods of life and brain development still occurring. So with that, I want to take this real world anecdotal sort of push and challenge us to ask, what do we actually know about the brain in pediatric chronic kidney disease? Now, to do this, I recognize I need to give you context because many people in the room may not have much background in cognition or neuropsychology, neurocognitive aspects of care. And so I like to sort of think of myself as a pseudo neuropsychologist. I get to have the best of both worlds. I love being a kidney doctor, but I also get to really have a niche expertise in the brain as well. And so before I get going, I do want to help you understand some of the terms we'll be using in the next several slides. So when we talk about cognition, again, it's the brain's ability to undergo and partake in multiple different aspects of how we think. Globally, there's a term that we use called intelligence or IQ that sort of reflects an umbrella term for how well one can think. Oftentimes intelligence testing includes components of memory, attention, and behavior as well. There are other components as well that are included in cognitive assessment, such as something called executive function, which we're going to spend a lot of time on today, and I'm going to come back to that in the next slide. And then general development. How are our patients' gross motor or fine motor milestones? Because certainly the developmental aspects of our patients that we see, their ability to feed themselves or so forth, really also play into then concerns if there are cognitive deficits with actually how we think, if we can't also have global motor or global development as an individual. All of those things go together. So a developmental history is an important part of a cognitive battery. Some of the measures we'll be talking about include the Wechsler scales, two different Wechsler scales that we'll talk about a little bit, the WASI and the WISC. And again, this is a global measure of cognition. Executive function will particularly be two measures that we're really going to talk about. One's called the DKEFS, the Dellis-Kaplan Executive Function System, and then the other is a parent report form called the Behavior Rating Inventory of Executive Function, or the BRIEF. And then lastly, there'll be a little bit of discussion about attention specific to a computerized task called the CPT. So how do we define executive function? Recall just a moment ago, I told you I'm going to spend quite a bit of time on this because I think it's a very important component of what we are evaluating with a cognitive assessment. So executive function, many of us have heard of sort of the term plan, do, study, act. It's something we think about with quality improvement in our day-to-day care for patients. I like to think of executive function as sort of the brain's own quality improvement cycle. So instead of just simply plan, do, study, act, we have to add a couple of components in with executive function, where our brain is constantly thinking in a way that says, okay, yeah, I see that dog over there. Oh, well, maybe I don't know that dog. Maybe I should think a little bit more before I go and pet the dog. And so all of these very subconscious and unconscious components of thinking and planning and doing happen with everything we do. So again, our brain is constantly undertaking these sort of think, plan, do, stop and evaluate cycles. And ideally, or most purposefully, we would hopefully learn from these constant cycles of decision making. To have really intact executive function and be able to have an intact cycle here, you have to have components such as impulse control, attention to the decisions in the environment around you, to be able to control your emotions, and then integrate that with memory and different planning capacities, and the ability to self-monitor your own behavior. Again, most of these components happen really without us even recognizing them. And so it becomes quite obvious or evident sometimes that if there are gaps in these core executive function components, then certainly kind of the walls can start to fall apart around our decision-making safety. So as we jump into the next several slides, I want to just talk broadly about cognition with a focus on some of these umbrella terms, such as intelligence and development. And then we'll come back in the next few slides about executive function. So intelligence. Intelligence, as we talked about, is IQ. And so one of the studies that, or groups that has done really probably some of the most robust work on this topic is the chronic kidney disease in children cohort, or CKD. The CKD cohort is a prospective multi-center cohort here in the United States. Brad Wardy and Sue Firth are the co-leads on this study. And one of the core components or core aspects of the CKD study is to really understand brain development in the context of pediatric chronic kidney disease, as well as CKD progression, growth, cardiovascular outcomes, and so forth. So the CKD study has looked at neurocognitive functioning amongst the whole cohort of children with mild to moderate, so pre-dialysis, pre-transplant chronic kidney disease. Among the sample that's been published thus far from the CKD study, they have over 368 children with data as of, this was even 10 years ago now, that were published in this study, in this paper listed above. And with the CKD study, it looked at, again, these children had mild to moderate chronic kidney disease. They underwent intelligence testing, some executive function and attention testing as well. And so in the CKD study, what I have highlighted here is the percent of patients at risk for neurocognitive status, so at risk for poor neurocognitive performance. And so I've listed several different domains on this slide, including domains of intelligence, such as the verbal intelligence or performance intelligence, which is basically your nonverbal intelligence. I've listed attention parameters. The Wyatt is an academic achievement scale. So a whole different list of parameters that were evaluated in the CKD study. And the dashed line represents the scores that are a percent of patients with neurocognitive scores that fell greater than 1 standard deviation below the mean, specifically meaning, again, at risk for neurocognitive impairment. And what I want you to take away from this slide is that neurocognitive functioning for the broad CKD study really is within the average to slightly low average range. But importantly, when we look at intelligence, attention, executive function based on the CKD study, there are some potential disease-related factors that predict risk. So protein in the urine being associated with a lower IQ, lower intelligence, and also proteinuria being associated with problems with attention and executive function as well. Again, these are associations with risk, and so not necessarily causational, but an association that's noted within the data. So the CKD study also has nice data that has looked at actually the neurocognitive and developmental outcomes for kids that were diagnosed with chronic kidney disease early on, and looking at these outcomes even in preschool age children. And so this next slide, I do want to highlight the work that's been done to try to characterize the brain or cognition in early chronic kidney disease, early aged chronic kidney disease patients, I should say. So in this paper with Steve Hooper and colleagues, again from the CKD study, 124 children in the CKD sample who were in preschool or preschool aged at the time of assessment had data available for evaluation. as with the last slide, these children had mild to moderate chronic kidney disease, pre-dialysis, pre-transplant. And as you'll see again here, we've characterized the percent of patients at risk for neurocognitive impairment. And similar to the last slide, you can see here the little dashed line, and the dashed line represents scores that are greater than 1 standard deviation below the mean on a cognitive assessment. And so here you can actually see across a couple of different domains, in particular development and intelligence. Nearly 1/3 of these preschool age children were at risk for low development or executive dysfunction based on these assessments, which is pretty, I think, sort of, wow, like makes you stop and think and take pause that these neurocognitive impairments could be seen this early on in life. Again, they're subtle but present neurocognitive concerns within this sample. And as I mentioned, again, amongst this sample, there are some potential predictors or association markers between kidney function and cognition. With this sample specifically showing that lower kidney function and actually anemia were independently associated with developmental scores in this sample. So what about school outcomes? I think school outcomes are potentially something that maybe we underestimate or overlook a little bit in our day-to-day practice. This is something that I'm very passionate about, and I think most of my patients would tell you that I ask them about this fairly regularly. How are you doing in school? Do you like school? You know, are you getting help in school? Because school is, in my mind, a direct reflection of cognition, right? That should be fairly, no pun intended, a no-brainer. And that if you're having trouble with cognition, school might be harder for you. And so again, this is data from the CKD study, chronic kidney disease in children prospective cohort study, where we look specifically at academic achievement. The data on the left-hand side is published data where, again, we look at the distribution of academic underachievement in the CKD study. And these are pre-dialysis, pre-transplant CKD patients. And you can see, again, similar to the last two slides, that about 1/3 of the sample are performing approximately 1 standard deviation below the mean in reading, mathematics, spelling, and just total academic achievement. But mathematics does seem to be the domain that has probably the most pervasive difficulty with academic achievement. The data on the right is accepted, soon to be published data, looking at educational attainment and employment outcomes in the CKD cohort. And I think this data is pretty, again, it's new data, and it's really looking at the whole of the CKD cohort since its inception. And if you look at educational attainment by age 20, so we're kind of giving our patients a couple of extra buffer years to potentially have finished school. By age 20, the majority of patients have, or near majority of patients have completed high school with maybe some college, about 49% of the sample. As you get further out from that period of time, even at age 20, you know, you can see that some patients actually have had a head start somewhere along the line and started some college age classes, maybe even in high school. So we do have some high achieving patients where they're actually getting college done potentially even early, and 2 to 3 years of college by age 20 otherwise, which is probably age appropriate. But interestingly, I've just told you that a decent number of our patients are actually doing reasonably well educationally. If you look at employment status amongst the whole cohort available at age 18, again, the majority are working, but there are quite a few patients in the CKD cohort who are actually not working, have disability, they're seeking work, not working though, and or not seeking work. And the latter of these three categories here are overall quite different than what we would see for general unemployment in the population within the US. The current unemployment rate, I think, approximating 5% or less. So this is certainly greater than we would probably expect in juxtaposition with the educational attainment that otherwise is being achieved in the CKD sample. So suffice to say, as we talked about early on, financial and educational outcomes are important because amongst these patients who are disabled, not seeking work, or seeking work and currently unemployed, certainly they may be at financial risk when it comes to their overall care. So we've talked about, again, the developmental components of the brain, meaning we know that there are white matter and gray matter changes in the brain over time for developmentally otherwise normal children. We know that there are cognitive risks for this patient population with chronic kidney disease, specifically cognitive risks for maybe some lower IQ, risks with executive function, risks with academic achievement. But can we actually take those potential risks and put them in juxtaposition with brain data, with neuroimaging data? And historically, I think folks have been really interested in this topic nationally, internationally, for quite some time, trying to say, can we take a brain phenotype and predict cognition? The problem has been that neuroimaging studies that have been historically done are limited, more or less, and they're limited on a variety of levels. In particular, it's very hard to do neuroimaging studies in any population. And the majority of times, published data has looked at qualitative imaging, meaning we get a scan for a clinical purpose, and then we go back and look at the scan from a CT scan or an MRI scan later on and say, well, it looks maybe like there's less gray matter, or it looks like there's less white matter, but we don't have a discrete number to compare apples to apples with. Unfortunately, too, published neuroimaging data on this topic has also oftentimes happened in the absence of cognitive assessment. So again, it's challenging to get a full comprehensive view of a patient because if you, as we'll talk about, which we've done here, it takes a pretty big day of research participation, getting an MRI scan and cognitive data all in the same fell swoop. So many studies are published in isolation of each other. The other challenge, too, is that pediatric chronic kidney disease is a relatively rare disease, right? And so to be able to get an adequate sample size, sometimes we get a little bit desperate with our research and we say, we're just going to put everybody with chronic kidney disease in the same basket. But I could argue, I think, quite compellingly that a child that's born with chronic kidney disease has a very different life course and different developmental phenotype than a child who has lupus later on in life. So how do we accurately compare those two populations? And furthermore, many of the studies that have been published thus far just, again, take dialysis patients, take transplant patients, take early CKD, and is it justifiable and is it warranted to really compare those patients together? Lastly, again, we try to get as many patients as we can, and as we've shown earlier, there's so much brain development that occurs and changes between early childhood and early adulthood. So is comparing a 6-year-old with a 25-year-old brain really appropriate either? So our group, my group here at the University of Iowa, has tried to address these gaps through the following research that I want to kind of walk you through, because I think this helps us to sort of bridge the gaps between what's known and unknown in our field. So since now 2016 here, we've been undertaking what we fondly call the Brain Kid study, the brain anatomical imaging and neurocognition in chronic kidney disease. And so with the Brain Kid study, we've really looked primarily or exclusively at children who are born with congenital anomalies of the kidney and urinary tract. And we've compared them to matched healthy controls. I do have a fairly widening age span between 6 to 25 at current, and the older age span is actually occurring to allow us to accommodate multiple visits for these patients. The data I present today, though, is simply a cross-sectional view of the early data that we have and does not reflect the longitudinal imaging that we are currently undertaking. In the current sample as well, we've really focused on pre-transplant, pre-dialysis, so no transplant or dialysis patients in this sample. And it's also important too that I don't want to bias the sample by saying, well, I know this patient has intellectual disability, let's skew our data. So we've tried really hard not to do that and are enrolling only patients without a formal diagnosis of intellectual disability. Also trying to avoid the impact of prematurity on brain development. So our exclusion point is basically any child that was less than 30 weeks gestation was also excluded from potential inclusion. Importantly, the data that we'll talk about, the children involved don't have spina bifida. There are no other CNS anomalies, again, that could potentially bias our findings. And this is important because it's also limited the number of females that are involved in the study just by nature of the disease status that we're recruiting. Again, I want to talk about this slide a little bit more because I think it's important for me to share the data that we have available on this topic because it's pretty robust. We have biospecimens, we have cognitive testing, and we get an MRI, and all of this happens in a single day's visit. It is a long visit, so certainly it can be challenging to get patients to participate in a full day because the parents are taking off work to do so. The imaging study data that I'll present as well, it's also important to note that this is non-sedated imaging. So these children have to be able to lay in a scanner without sedation. And the MRI, the neuroimaging data that I'll talk about, has several different components, including white matter, gray matter, brain volume, and some other data that I won't have time to present today, looking at brain function and brain metabolism. So the sample that I'll talk about in the next few slides to talk about brain imaging in relationship to cognition is a modest size sample, but I think it's powerful in that we have very clean data, as I've tried to emphasize on the slide before. We have 18 children in the sample that I'm going to describe to you today. They're males only due to challenges with female recruitment by nature of the disease inclusion and exclusion criteria. Within the sample that we're focusing on with males with chronic kidney disease, we have 18 kids compared to 24 otherwise healthy comparators. And this slide really is trying to highlight that it's a well-matched sample with the exception of their kidney function, their estimated GFR. In my chronic kidney disease sample, the mean estimated GFR is 75, with a span drifting down into the low CKD stage 3B range as well, which I'll show you on the next slide. Again, they're also very well matched with parental socioeconomic status, which is important, I think, given the impact of socioeconomic status on potential development and just risk for social disparities. Again, maternal education, blood pressure, prematurity history are all otherwise very well matched as well. Within the chronic kidney disease sample, this is, I think, again, important for me to show you because I want you to understand that these are healthy kids with chronic kidney disease. Their mean GFR range spans stage 1, 2, and 3 estimated CKD status. The duration of chronic kidney disease in the sample is reflective of essentially their age, since these are all congenital anomalies of the kidney and urinary tract. None of these patients are anemic. None of them are, well, I shouldn't say none. There is a little bit of a drift down towards the lower end of hemoglobin, but none with a hemoglobin less than 10. None of them were on an erythropoietin stimulating agent. They had normal bicarbonate ranges, so really no acidosis and really mild proteinuria as well. So what have we found in this study? And this is one of the things that I'm so excited to share with you today because I think this is cutting edge data that certainly I use in caring for our patients here at the University of Iowa. So let's walk through the cognition data and then the brain data from neuroimaging. So we've talked before about intelligence, general IQ. And so similar to the CKD study, we administered very similar tests to set us up to say, yes, there are or are not differences in how cognition looks in the sample. So one thing I want to emphasize here is the blue line are the chronic kidney disease patients, the controls, the healthy comparators are here on the red, and the standard scores at the bottom of 95 to 120. Now, again, in full transparency, it's important for me to be very clear that one of the risks of recruiting healthy controls in a university setting is you can get very smart controls, which we have certainly gotten here with you. As you can see, the overall IQ is very robust in our controls. But our chronic kidney disease patients aren't too shabby either. They're very well within the mean and the expected range for intelligence. So although our chronic kidney disease group did score consistently lower than the healthy controls, they're still doing overall very well with their overall global intelligence, or IQ. Now, on this slide, this measure called the RAT is an academic achievement or academic assessment test, the wide range achievement test, another Wechsler type scale. And so with the wide range achievement test, you can see also here, really scores between 100 to 105 are overall actually quite appropriate and normal. So like with the last slide, if it's not necessarily earth-shattering to think that if you have good IQ, you're going to have good academic achievement. And that's really what we're seeing here, is that academic achievement is overall pretty normal for our patients. Slight leftward skew compared to healthy controls with arithmetic, as with the CKD study, arithmetic also being slightly lower. So we've said that there's a slightly lower shift on intelligence, a slightly lower shift on arithmetic. Now, as we look into some of the more higher level cognitive capacities, we've looked specifically at executive functioning in this study, with a really kind of fine-tuned emphasis on that, using multiple measures of something called the DCAFs, which we talked about earlier, is a measure of executive function. And it's actually multiple subtests that you can actually have individual subtest scores and a global score. And here I've shown you subtest scores across all of the domains tested in the DCAFs. And notably, there is no DCAF subtest that our chronic kidney disease patients actually outperform the controls on, but there's global leftward shift again of the data, lower scores reflecting worse performance across all of these domains. And there are a couple of domains that you can see here as well that are related to something called sorting. And sorting is an inhibition and memory task where you have to actually stop, think about what you're doing, and then remember what you've done to actually do well on this test. So these sorting tasks are the tasks that are the lowest performing in the cohort. So mild deficits in intelligence, and deficits is probably even a poor term, mild leftward shift in all of these domains that we've looked at. So our kids are overall, I would say, phenotypically, they look pretty healthy. They're cognitively doing fairly well. But what do we see in the brain? Is there anything different in the brain anatomy, the neuroanatomy, the neuroimaging that we can detect? This is actually the research scanner that we use here at the University of Iowa. It's research dedicated, and so which is great because it's really suited to helping kids perform a non-sedated scan. We're able to take the time to coach them through the scan. They get to watch a video inside the scanner, which the kids really enjoy. And it's this kind of cool spaceship theme. So they, especially for the younger kids, they feel like they're going into outer space. So we try to make it an enjoyable experience for the children. And I'll also say that I think this for me has been a learning experience because I have really become more accustomed to feeling confident with non-sedated imaging. And so even translating that into clinical work, having the discussion that, yep, kids can do this if we can take the time to help them do a non-sedated scan. So within brain findings, we can see neuroanatomy or brain regions. We can see the frontal lobe, we can see the parietal lobe, the cerebellum, and we can break that into gray matter, those dendrites or the cell bodies, right? And then the white matter, the highways. And think back to that slide from the very beginning where I told you, I want you to remember the gray matter goes down with time and the white matter goes up with time. And so keep that in mind as we look at this slide. Because interestingly, in several areas in the brain volumes here, we're seeing some differences with our chronic kidney disease patients compared to controls. And I want to be very clear that these differences are quantitative, meaning they're not just a visual representation. When we do our scans, the scan data is processed through some very sophisticated computer programs where you get an actual estimated volume. And so we can take a discrete number and compare peers to kids with chronic kidney disease, our affected patients, and say, truly is the number different? And so herein you can see that when you compare the zero is essentially the healthy peer group data or normal data. You can see over here that the cerebellum, the gray matter of the cerebellum is significantly smaller than compared to zero, compared to peers. And interestingly, the cortex, the cerebrum, the cerebral gray matter is actually higher than expected, which is really quite interesting, right? Because I just said we're supposed to see lower gray matter, especially in the cortex over time. But gosh, the cerebellum is even lower than you would expect. So what does all of this mean? Does it mean anything? So we asked that question and said, well, let's take the cerebellum and the cerebrum data, the cortical data, and plot it against some of the cognitive categories that were most affected in the CKD group. And what we found was actually that those gray matter volumes appear to be associated or potentially predict some of the cognitive findings that we've seen. In particular, the lower your cerebellar gray matter volume, the poorer the performance on some of the DCAFs, executive function tests. And interestingly, then sort of conversely, the more gray matter you have in the cerebrum, so again, we said it should be lower with age, but the more you have, it actually predicts the academic achievement testing for the domain of arithmetic. So that was really quite interesting. And then we said, okay, well, let's see if kidney function can predict any of these differences either. And again, keep in mind, this is a modest size sample, but we feel pretty excited about the data because it's clean data. We know what we're working with. And interestingly, the lower the cerebellar gray matter volume, the lower the GFR, or vice versa. The estimated GFR, the kidney function, actually predicted the cerebellar gray matter volume. Now, okay, so why the cerebellum? Why am I talking about the motor function area of the brain? That's what we all associate the cerebellum with. But as we kind of dug into it further, it's really quite interesting. The cerebellum has a lot of functions that I think oftentimes we don't give it credit for. In particular, the cerebellum has these very discrete and very elegant connections through the brain to the cortex, to actually the frontal component of the brain. And these functions of the non-motor cerebellum are highly involved in executive function, which maybe gives us a little bit of a hidden link that maybe we haven't been thinking about before historically in this field. Maybe there are other components of the brain that we need to look at, not just volume, not just the brain appearance, but actually the connections, the white matter components. So that takes me then to the white matter, the highways that overall connect areas of the brain, that connect the cerebellum to the frontal lobe through multiple little discrete stops along the way. So again, I have to be very thoughtful about how much data I put out into this talk today, because again, I can talk about this probably for hours, but I want to emphasize the white matter globally. So white matter, we can get a global volumetric and global integrity measure of the white matter in the brain. And white matter and the myelin of the axons that connects different areas of the brain is very water dependent. There's a lot of water content to that. And so that can be actually measured through a marker called fractional anisotropy. And again, these are very neuroimaging based terms. So I don't expect anybody to come in with an understanding of this, but I want you to understand subsequently, though, that white matter integrity, or the health of the white matter, can be measured through these imaging studies that we do. And what we found, even in this early chronic kidney disease, is if you take a global measure, a weighted measure of all the white matter in the brain, the white matter integrity is globally lower for our chronic kidney disease patients relative to healthy peers, with evidence in specific large areas of white matter that there are definitely differences that are driving this. So then it should make us take pause to say, well, gosh, is there any way we can detect these differences before they occur? Is there any way we can actually say, well, hey, these kids are at risk for brain developmental differences. They're at risk for neurocognitive abnormalities. Can we actually measure something before these changes start to occur to potentially then help ameliorate the concerns long term? So one of the areas that we've been interested in as well is, can we take markers in the blood to predict differences in chronic kidney disease patients and their brains compared to healthy controls? There actually is a really sophisticated brain protein marker that you can actually detect reliably in the blood, just as reliably as if you were measuring in CSF. And so In these neurofilaments here, you can see these areas within the brain. This is again the cell bodies and the axons. If you have an injury to these white matter axons, you can release neurofilaments or little neuroproteins into the blood. Again, as I mentioned, older assays actually could detect these neurofilaments really only in blood, but with more new third and fourth generation assays, quantitative PCR assays, you can actually detect these neurofilaments in the blood just as reliably as in plasma. And so, again, the neurofilaments that we are looking at contribute to the growth and stability of white matter, of the axons within the brain. Highly expressed in white matter, although there is some gray matter expression as well, interestingly. The levels of these neurofilaments increase with axonal damage, and most of the literature on this topic has been seen in traumatic brain injury, aging and or cardiovascular disease, hypertension, interestingly, other neurodegenerative illnesses, which wouldn't be surprising if there is brain change over time. We don't think these proteins are impacted by chronic kidney disease. We don't think that progressive decline in CKD impacts the level of the excretion of these proteins long term, but the data are slim on that, just to be transparent. So what we did is actually we had permission from our patients to actually store blood for future use as part of their participation in the study. And later, as we've gotten further on down the line, we took these samples and sent them to a lab that measures these neurofilament pieces in the blood. And interestingly, we saw very early on in chronic kidney disease that there are differences in the levels of these neurofilaments in the blood. So over time, with age, which is a proxy for disease duration in our patients, you do see an increase in the neurofilament light chain level in the blood, so increase in neuroinjury compared to the relatively flat red line for healthy controls. And interestingly as well, you see here, as I mentioned, the neurofilament injury is largely expressed with white matter, although there is some gray matter injury expression as well. And those with lower cerebellum volume had higher neurofilament light chain levels. Again, which is interesting to see that we actually could find a true, very significant association between these markers. So the data that I've presented thus far are all pre-transplant chronic kidney disease, pre-dialysis chronic kidney disease. And what I want you to take away is that there are subtle differences that are present early in this sample. There are brain differences that are present early in this sample. And it's possible that we're able to see relationships between these brain differences with disease parameters, such as estimated GFR and markers of brain injury. Now, the question I always get, and I think it's an appropriate question, right, is does a kidney transplant fix it? If we transplant our patients, does this reverse the brain phenotype, the cognitive deficits that we've observed? And I think this is an important question to really phrase again globally, that transplant is never an isolated medical issue, never isolated, because there's always the complication of immune suppression and or surgical complications that come. Some of our patients wait for a long time, unfortunately, on dialysis before they get to transplant. How does that time on dialysis impact the post-transplant recovery? Again, lifelong need for immune suppression. The oncology literature would argue that there is definitely a detrimental impact of glucocorticoids on the brain. How do our steroids for transplant or our calcineurin inhibition medications impact the brain? And really, I think the most critical aspect of it is that this is a chronic disease state. So we're always hopeful that our transplants will last, as long as possible. But unfortunately, sometimes that isn't the case, and we're transplanting a patient again more quickly than we expect. And I think clinically, most of us that are taking care of transplant patients would probably argue and be quite valid in saying that we see the most notable cognitive deficits in the 12 months leading up to transplant. And I think, again, most of us would think that, yeah, in clinic, when I see my new transplant patients, they're saying that they can think more clearly, they can do better in school. But does that brain phenotype fully reverse from what we see in chronic kidney disease? So this data is data from my center here at the University of Iowa. And as I mentioned, sometimes this data takes a while to collect. Chronic kidney disease transplant is fairly rare comparatively to other pediatric chronic diseases. So what we had undertaken here since 2015 was a longitudinal assessment of a cognition pre and post transplant. So as standard of care, we strongly recommend and provide opportunity for cognitive assessment for our transplant patients in the pre and post transplant process. So when a patient's referred to us, then we refer them for cognitive assessment pre-transplant and then get repeat testing at least a year post-transplant. And we do this for all kids ages 3 and older using age appropriate scales. So in this slide, what you can see is that we have a number of patients. All of the dots represent a cognitive testing point. And some of our patients have pre and post testing. Some have pre-transplant only, some have post-transplant only. And so we can take a statistical approach to actually accommodate all of these numbers, all of these points into a single model using a mixed models approach to estimate potential change over time or change relative to an intervention. And so our question here again was, does transplant impact cognition? And so these two slides, the panels A and B here, which was data that was recently published in Pediatric Transplantation by one of my students who is starting medical school this fall. I'm very proud of her. She and our team looked at these changes over time between transplant or cognitive scores. And so here you see an estimate for transplant status. So basically this is saying, do the pre-transplant patients perform better or worse than the post-transplant patients or vice versa? And so the status variable here is basically post-transplant. So what this shows is that our kids that are post-transplant are actually not catching up to their pre-transplant peers in a couple of domains, specifically something called processing speed. And processing speed is basically how quickly can you use information that you're given? How well can you integrate it together to then perform a task that may require rapid manipulation of information? So this is really interesting. We expected the post-transplant patients to actually pick up on some of these outcomes, such as IQ and again, processing speed. So we tried to internally validate this measure and said, well, for those patients, the 11 kids that had both pre and post-transplant testing, let's see if this really stacks up based on the models that we've run. And if you look at just the kids even that have both pre and post-transplant cognitive testing, this finding holds up very, very reliably, which again is showing us that patients who received a kidney transplant, interestingly, even at a year post-transplant, are not making up as much ground on specific domains that are really important for decision making, attention, memory. This processing speed impacts all of those components of cognition. So we wanted to say, okay, well, is there something that we can do to kind of predict these findings? Are there certain patients that are more at risk for non-recovery of their processing speed after transplant? So we looked at dialysis modality, we looked at disease etiology, and we also looked at age at transplant. And out of all of these different clinical factors that we have seen, age at transplant seems to most clearly predict the non-recovery of processing speed. So if you are transplanted earlier in life, so we did a split of the population age, there's a bimodal distribution, not surprising, and we split at that bimodal distribution and said at 80 months age, what happens if we split there? And so kids that were transplanted earlier in life had better recovery of that processing speed after transplant. Conversely, the kids that are transplanted later in life don't seem to reflectively improve that speed. And then, so you think to say, well, why? Why is that? Is it disease duration or what is it exactly? And one of the components of cognition that's a little bit older theory is the idea of what's called fluid or crystallized intelligence. And so crystallized intelligence is sort of, you've got what you've got and it may not change. Fluid intelligence are the parameters that sort of become experiential in nature, things that you learn from literally doing life. And so our thought with this is that potentially this age at transplant greater than 80 months simply reflects probably a component of chronicity of disease burden, and just the brain's sort of inability to recover some of those more crystallized functions. But again, this is theory. This is what we think, and I don't have a good way to validate it right now. But it's something that I think really warrants further investigation and evaluation. Is the impact of our age at transplant on long-term cognitive outcomes? So, as I mentioned again, right now, things like that we've seen in our sample with transplant suggest that long-term, our patients could still be at risk for cognitive impairment even after a transplant. So even after a transplant, when we're still giving them complicated routines, sometimes for nutrition or medications, they're still at risk for challenges with cognitive deficits. Certainly in the long term, all of the work that I've discussed today, the impact with neuroimaging, the cognitive components, the biospecimen components, all of these things require further investigation. And that's currently what we're doing. And I'm really excited to be able to hopefully start sharing some of that data in the next 6 to 12 months, as we now have longitudinal data elements from the brain components with neuroimaging. We can say, okay, actually, this is what brain change over time really looks like in relationship to disease progression and cognition. Certainly, again, all of these directions require larger samples. They require more gender distribution and equity, and they require longitudinal follow-up with our biomarkers and kidney parameters, with the ultimate goal that with all of these things that we're doing, as a parent and a nephrologist, right, I want to see my kids, my patients, become successful adults, as do all of us. And so the goal being that we want to be able to identify variables that improve cognition, can predict our ability to improve cognition, and ultimately help our patients have a healthy and happy life ahead of them, where adherence and compliance and educational and employment success aren't such a struggle as they are for so many of our patients. So these are some of my kids here at the University of Iowa that I'm really proud of. And again, images from our marketing department. But just to, again, emphasize that we want our patients to be happy, healthy, and successful, and attention to the brain in parallel to their clinical care. I think it's a 1-2 punch. We have to do those two things together in order to help our patients really succeed into adulthood. So with that, it looks like I'm exactly at an hour. And I want to take a moment to thank so many people who have helped me along the way, my work family and my own family. No talk is complete without pictures of cute kids. And so my own family that supports the work that I do through their time and love, and just a fantastic work family. And certainly couldn't do this without my amazing postdoc student and colleagues in neuroimaging as well, as listed here. And certainly thank you for the funding that I've been able to receive from the NIDDK and my own department at the University of Iowa. So with that, I'm happy to take questions and just even discuss if this discussion is amenable as well. However, folks best want to interact.
Thank you very much, Lindsay, for that excellent talk, which was very stimulating, certainly, and has thrown up lots of things that we need to think about for the care of our kids. Can I just remind people to post their questions on the chat, and we can pose these questions to Lindsay over the next time. Should we start off with the first question that's come through? It's got two parts. In relation to the school outcome data from the CKD study, is this any different than children with other chronic diseases? And the second part is, could this be related to the number of admissions to hospital or the number of acute illnesses that they might be experiencing?
Yeah, that's a great question. And it's one of the questions too, I think, that oftentimes, you know, I do get this sort of question or this pushback. Well, is it simply a sick kid phenomenon, right? Is just being sick the precipitous to seeing what we see? Do kids with diabetes have the same have the same cognitive phenotype, et cetera? And so I'm going to come back to that first part of the question and answer the second part first, because I think it is important. So there's really nice data, again, from CKD, and in particular, Kelsey Richardson, who is a nephrologist in the state of Oregon, has really been interested in this, in the idea of school absenteeism. And unfortunately, but not necessarily surprisingly, there is a fairly high amount of chronic absenteeism in the CKD cohort. As I recall from that data, I think some of our patients may be missing up to 16 days per academic year, which that equates to about 2 days a month, which certainly is not insignificant. So chronic absenteeism can certainly be a problem. And the absenteeism can occur for a variety of reasons. Certainly, illness related to the disease, and or sometimes even the concern that maybe there is bullying for patients or psychosocial components that they don't want to go to school. So, and I put that up there because of interest, I think, in Kelsey Richardson's data from CKD, there actually was a higher rate of chronic absenteeism in kids that are requiring catheterization. So, one could say, well, maybe again, they're more at risk for urinary tract infections, but maybe also too, they just don't want to go to school because they feel isolated. And so I think there are so many components that really would warrant kind of this a qualitative assessment with patients and families that are going through this to really understand how their CKD impacts their school absenteeism. Now, with regard to the actual academic achievement data, so CKD has not directly looked at the academic achievement data with other chronic diseases. And one thing that we've done here and kind of explored a little bit actually is the academic achievement data for my own kids in my cohort compared to a hemophilia cohort that one of my colleagues at the University of Iowa has looked at. She has some smaller pilot data, but basically used the exact same protocol we did so we could have some matched data. And my kidney kids actually still underperformed compared to the hemophilia patients. Which is interesting too, given that, you could argue that it's also similarly lifelong chronic disease. It's probably a decent enough match for trying to say risk for underachievement. There's decent data from the diabetes world in particular that suggests, again, risk for cognitive dysfunction, but a little bit less has been done on academic achievement globally in like diabetes per se. The oncology world, actually, our group here at the University of Iowa has really looked at academic achievement with the oncology population. And similarly, I think seen some academic deficits. And interestingly, in that population too, similarly, some more deficits in mathematics. And so one could argue that, again, the academic downstream effects might be a result of the chronicity of disease. They might be a result of being out of school. But ultimately, I think those are all important components, whether or not it's the kidney, the chicken or the egg, the kidney or the brain, right? It's important to recognize since there are so many downstream effects with academic achievement.
Great, thanks, Lindsay.
Thank you, Lindsay, and thanks for a really wonderful talk. What a great overview of the cognitive effects of CKD and also obviously an introduction to the wonderful research you're doing. There are a number of questions. I'll read you the next one. What has changed in your day-to-day practice based on this data?
That's a great question. So one of the things that I think, so sort of probably twofold. I do a lot more teach back maybe than I did 5 years ago. And so with teach back, meaning I try really hard to make sure I'm instructing both the parents and the patient. And so I really try to include the patient starting really probably around age 10, when they, I think, have a little bit more capacity to kind of buy into what you're talking about. So as we teach them about their kidney disease or their phosphorus or whatever, I try to make sure that I'm hearing back from them, a direct repeat back of what I'm saying. So having them explain to me, well, why do you have kidney disease? Or what does a transplant do? And even just asking the question sometimes for a patient that's maybe been a kidney patient their whole life, but they're really just starting to kind of understand the process, now. Sometimes I even ask them, you've been our patient for a long time. Do you know what your kidneys do? And it's remarkable to me, the number of kids that will be in our care for years, right? And they're part of routine follow-up with us, and they can't answer that. And so then taking that basic understanding of, okay, you don't understand what your kidneys do, so let's talk about it. And then why is it important for me to be saying, well, you can't eat this, or you shouldn't eat this, or you need to eat this, right? So really trying to gauge a better understanding from both the patient and the family, and always being aware that just because I think I'm saying something in plain language doesn't mean I am. So I think that teach back component is really important, to hear from the patients what their understanding of what you're saying is. So that's probably one piece that I'm very, very purposeful with in my encounters. And then secondly, I actually try to be very, very prescriptive about asking about every 3 to 4 months, what are your grades in school? Are you getting help in school? And sometimes I'll be very honest, sometimes I'm embarrassed that we have patients that are even in my own practice that I thought we had better educational assistance for them, and we don't. So for me, that's important because, like we've talked about, education is sort of the downstream effect of a lot of these things, the chronicity of disease, the potential intelligence or attention components of CKD. Education hits right at the funnel of all of that. And so if those other components are awry, then again, their school performance is going to suffer, which has direct psychosocial and education or employment outcome downstream effects. So making sure my patients have support in school, that they know that they're not alone, I think is also important, because sometimes our families and our kids struggle in silence because they're like, my child looks fine, right? They are active, they're otherwise fine, but they have CKD 3B, right? And so they struggle a little bit in silence, trying to understand what's going on, that my kid is struggling so much in math. So trying to really be direct and purposeful about that. And it takes maybe 2 more minutes of time, right, in my clinic encounter, but it's 2 minutes that I think are very meaningful, because I think they have a direct real world impact for my kids.
Lindsay, can I ask you, what's the parent's reaction to possibly the bad news that their child might not be so bright, might struggle at school, might have these issues? Are they depressed by it, or as you intimated, they accept that it's part of the long-term disease process?
Yeah, I try to, that's one of the things that I sort of have internally wrestled with a little bit, like, okay, well, is the work that I'm doing actually really like depressing to my families? And I hope it's not, because I think what we're starting to show is that, yes, these deficits are present. They're generally subtle, but recognition, I think, can be an important component of empowering families, right? And so, for example, clinically, I primarily do transplant work clinically. And so when I do a transplant evaluation with our chronic kidney disease families, I try to talk very clearly about, look, we know in our data that kids with chronic kidney disease might have more trouble with remembering, might have more trouble with attention, might have more trouble even in school. And sometimes it's interesting because families, like, the visible relief that I see sometimes when a family says, yes, we've been seeing this for years and we didn't know why. Okay, well, let's get you help, right? And so then conversely with that, then being able to say, then, okay, you recognize this, let's get you the services your child needs. And being able to have even like visual rehab to help with dyslexia, and tools that, maybe 20 years ago didn't exist, that we can actually make a positive outcome. And I've seen enough, I think, positive transitions from getting kids plugged into appropriate services, that I can actually then tell these families, like, hey, look, this is the possible reality with cognition, but we have tools to help empower you. And I think we have tools then to help make you more successful with transplant. And having these sort of frank conversations then also, I think, gives me the opportunity to say, look, after transplant, I'm going to specifically be checking on this. I'm going to specifically be asking you about your medications, because we know this, and I don't want you to fail. I want you to succeed with how you take your medications. I want you to succeed with, graduating high school. So I think overall, our families, at least in my own clinic, maybe find an extra layer of support through recognition. So.
Thank you.
Thanks so much, Lindsay. There's another question, and let me just paraphrase this a little bit. Is there a test that I can ask our MDs so that I could get a better sense of patients' level so I can address my teaching to the right level. I'm especially concerned about this because some of the kids often get upset because they're treated as younger than they are because they're shorter and not developing as quickly.
Yeah, it's a great question. It's something that's actually really high on my radar right now too, to kind of implement a little bit of this in our own clinic. There are actually like fairly quick, like standardized literacy and numeracy assessments. And literacy, health literacy, trying to understand really what do you understand, and trying to then say, actually, with these health literacy like assessments, it poses a relatively simple or straightforward question to the parent or the patient who's answering this questionnaire, and then you can get a sense too from that, like, okay, is the actual understanding of their disease process or health in general congruent with what we think. And so I think actually, as I'm aware, I think Dr. Greenbaum, I'm pretty sure that in your transplant program at Emory, they use some literacy screening tasks. I know in talking to Dr. Roshan George, that she's talked about that before. So I think there are some freely available screening tasks that can be implemented in clinic. And so that's something that we're actually working on in our own clinic here, is some basic screeners looking at literacy, and even how do you understand numbers, numeracy, right? How do you understand if we tell you to increase the medication by 0.1 mLs, what does that mean? So certainly some tasks that are out there. Unfortunately, this is probably not widely implemented across pediatrics or really many fields at this point in time, and it's something that could be probably pretty powerful in the general clinic. So.
Thank you, Lindsay. Just to get perhaps a more nutritional aspect of some of the questions, do we know if better biochemical control through dietary manipulation can improve any of these cognitive factors? It's a $64 question, I guess.
Right, exactly. So my gut answer would be yes. And so in particular, I didn't have time to present this, but data from CKD as well. We've looked at, for example, bicarbonate in the chronic kidney disease population, and interestingly found a kind of an interesting interaction whereby better bicarb levels, that little, like the more alkaline you are, probably is a little bit mildly protective against executive dysfunction. And again, these are all associations, statistical associations. But the adult data, interestingly, there was a very compelling editorial in CJASN about 4 to 5 years ago now, maybe even slightly longer, that asked the question, is acidosis corrosive to the brain? And so it's data from the SPRINT study in the mid 2010s showing the possible effect of acidosis on cognition in adult patients that actually also have hypertension with CKD, but still the effect of bicarbonate acidosis on the brain was pretty notable in that population. So that's one of the things that for me too, when I talk to families that are post-transplant, one of the things that we talk a lot about, because oftentimes families want their kids to be able to eat, they want them to be able to do everything that's normal as soon as they get a transplant. And we try to be very clear that, look, you have had how many years of a chronic disease? We have to rebuild the foundation of your body, and that takes good nutrition, that takes improved acidosis care, that takes improved vitamin D and phosphorus care. And so I think for me, like trying to frame and phrase all of these things together to say that actually having better bicarb is probably better for your brain, it's probably better for your heart and your bones. Those things I think make it literally, again, no pun intended, more palatable to take the bicarb, because it's one of the medications that I think our patients hate the most, at least mine do, since it's a big chalky pill. So having that discussion point where we can say this may actually help other things, and it's not just a number, is helpful.
There's another question here about social disadvantage and how much of a role it plays in some of the findings of your studies and the studies of others.
Yeah, I think it is kind of the $1 million question, since we are so, I think, acutely aware in our field of the social disparities that our patients face. Again, for better, for worse, and this is my own criticism of my own work. If I just focus on the data that I presented from my team, where we showed some brain differences and some cognitive differences, my patients are probably pretty lucky, right? We have Iowa is a fairly well-protected state. There's lots of resources for families, and the majority of the families in our socioeconomic status actually had potentially parents had 4-year college degrees. Both parents were employed. A minority of them, not significant, but a trending minority, right, were patients or families that needed more state support and assistance. So I think it's a good bad thing, right? Because my sample may not be generalizable to a sample in an inner city, because of the homogeneity of where we're at in Iowa. But maybe that conversely sort of strengthens some of the things that we've seen, because it is a fairly clean sample, and we're still seeing these differences. So one could then say or suspect that some of the cognitive concerns, especially the academic concerns, could be far worse in a larger, urban inner city area. So one of the things that we're currently doing is actually trying to recruit from other centers to participate in this work from the brain perspective, to really get a better sense of the ecological validity of what we're seeing. The CKD study has done a really nice job with this as well, and trying to account for disparities, and so including socioeconomic status, parental household income, and things of the sort in the analyses that are done. And certainly, especially with the academic achievement components, it's not surprising that the parental academic achievement and parental resources do certainly predict outcomes or predict worse achievement in the sample, which probably goes back to that holistic approach, right, to our patients, that if you're concerned that a family may need some social support, make sure they're seeing your social worker, or if you don't have a social worker, help them get plugged into somebody, some resources through your clinic, another clinic, whatever it might be, to at least recognize and try to help with those disparities, because I think it is it's definitely part of what we see and the things that we need to be aware of.
All right, thanks so much.
Lindsay, just another question. The patients that you have in your study seem to have better outcomes for cognitive function than those you described in the CKD study. Do you think that's just a reflection of the sample size, or perhaps the GFR of your kids was more favorable?
Mm-hmm. Probably a reflection of the sample. And again, Iowa, this is a humble brag here. Iowa schools are pretty good. And so our kids, I think, overall are well supported educationally. They're getting, most of them are getting services fairly frequently for different intellectual concerns, if there are any. So I do think that my sample is probably a little bit biased unintentionally to families that have a little bit more support, or more likely to have more support. So I think the kids are actually doing maybe comparatively better. So definitely one of the things that we have to look at is the external reach of what we're doing, and try to make it valid across other sites and settings. There's one thing that I thought of earlier that I'll just mention briefly, that is also potentially of interest. We have another like behavioral measure that we collected as part of the study, that's a self-perception or a self-concept measure, given that quality of life and things are so, I think, important in this population. And interestingly, the data from my group here, right, would suggest that even though kids are needing maybe some more school services, or they have trouble in school more often, their perception of that is just not there. These are chronic kidney disease kids actually think they're doing really pretty well, and they do comparatively as well as their peers on their own self-perception. So when I had mentioned earlier the idea of talking to families about how are you actually doing in school, don't just settle for good. Ask them what grades they're getting. Again, ask them if they're needing extra help, extra time, extra services, because I'm a little more and more convinced that our kids are sort of aloof to the difficulties that they may have at times.
Mhm.
Thanks, Lindsay. That's a great point. We see the same thing with how you're feeling. They say they are feeling great, and then you give them a transplant, and suddenly they realize how bad they were feeling
Yeah.
with their CKD, because that's what they're used to.
Yep.
We've come to the end of questions. That was someone typing to let me know there are no more questions.
Oh,
And so thank you again for just a wonderful talk and addressing the many questions we had from the audience so expertly and clearly, and really appreciate it. And thanks to everybody for the questions, and thanks for participating. And we look forward to seeing you at our next webinar.
Thank you all.
Thanks very much, Lindsay.
The next webinar, hosted by VitaFlow, will be on the 4th of September by Alicia Pavlik on the advantages and disadvantages of dietary modification methods to manage persistent hyperkalemia. On behalf of VitaFlow, we would like to again thank today's speakers and thank you for tuning in. Please take the time to complete the feedback survey that will be sent to you by email after the webinar. Goodbye and enjoy the rest of your day.